Good evening, Endo Summit Live, and welcome to the last Endo Summit Live of 2024. We have two fabulous guests with us here tonight as we conclude our season. Joining us from around the world, but particularly tonight from Washington, D.C., and often from Miami, is Dr. Gabby Mawad. Doctor, do you want to introduce yourself?
Yes, thank you for having me. I'm super happy that I will be sharing the last event with two fabulous people, my best friends. I'm Gabi Mawad. I'm a GYN surgeon. I do specialize in endometriosis surgery mostly, but also minimally invasive surgery in general. I work of the Center for Endometriosis and Advanced Pelvic Surgery in Washington, D.C. and in Miami. And I'm super happy to be here tonight with you guys.
Yay.
Yay, we are happy to have you. And also joining us from Atlanta, Georgia is Heather Guidone. Heather, can you introduce yourself? And don't be so modest, please.
I'm amazing. I don't know. Does that count? No. Everybody knows me. I'm Heather Guidone. I'm the program director of the Center for Endometriosis Care. I work with Dr. Ken Sinervo. We do obviously minimally invasive gynecologic surgery, specializing in endometriosis, pelvic pain gynepathologies, and we also are engaged in every aspect of advocacy that you could imagine, from legislation to research funding and everything in between. And it is so great to be here. You saved the best for last, and we love you. And we hope you have a wonderful event this weekend.
Yes, and neither of you are coming in person. Yeah, so I just returned from a day of the Hill on the Hill with AUA, which is the American Urological Association. And Heather, I think that you've done similar days like that. And I think that we could talk about a little bit about what something like that, what an experience like that is. I will say for AUA, unlike my experiences in gynecology, the money was flowing in urology. I mean, it's all about flow and more reasons than one. And from the time we arrived to the time they left, I didn't want for anything. We also there was so much soda, like in a conference, soda is really expensive to provide, but the urologist, there was like soda every minute. I don't understand. But you go in, every citizen has a right to go and do this. They had your meeting scheduled and they had your ask scheduled. So you were only allowed to ask about their three things. And because we came with the AUA PAC power, each office, we pretty much sat with the healthcare policy advisor for those offices. What is your experience like when you go for gynecological causes?
Well, very different. I mean, different in the sense that, yes, I mean, it's always put together really well because it's usually a pretty, high-reaching organization that hosts it. And they do. They're wonderful. They take care of everything. But it can be very difficult to go in there and speak to people who don't know about endometriosis, don't understand gynecology, don't understand pain and gender bias and all of the things that endometriosis is wrapped in. So you're meeting them and they're probably most of them are hearing about endometriosis for the first time, and now you're asking them for money. So it can be quite an experience. I mean, you really have to illuminate a lot of critical insights about the disease, explain why it's important. What are you asking? You can't just sort of roll up and say, listen, we need $50 billion. As much as I would love to do that, you need to have a specific ask. We want to fund meaningful, substantial research. We want to, get money that's being put towards the right studies for the right people. So it can be very daunting, but it's also very rewarding. And I think that the more of that, the better. And it's starting to become a little more commonplace, I think, now for most organizations. Like when you just went with urology, it is a different animal, but at the end of the day, it's the same concept. I mean, remember, they work for us, right? Supposedly, allegedly, they work for us. So you go in there as a professional, as a constituent, and you make your case. Do we always succeed? No.
No, and I think tonight we're talking about like future directions. And I think it's a very interesting, not to get too political before Facebook cuts us out, but I think that a lot of what's going to have to go on with the future of endometriosis in terms of also protecting rights as well is going to have to be at the political level. Do you have anything to say about that?
And I think everything is political, don't you?
Gabby lives in Washington, D.C.
But I believe that most of the political change is driven by people.
Yeah.
I don't think the awareness is the major thing that we can work on to raise the voice. And I'll give you an example. When you mentioned the urological stuff, I can realize that there are a lot of gender biases in medicine. And one of them, we deal with it every day when it comes to nerve sparing surgery and endometriosis. Nerve sparing, when we talk about like doing a prostate surgery, nerve sparing is a code that everybody has to do nerve sparing because the male will lose the erection. But for us, because if the nerves are damaged for any of our patients with endometriosis, what would happen is the functional troubles. There are bowels or bladder functional trouble that none of the traditional physicians who are not specialized will take care to ask about these kind of symptoms. So for me, the most important thing is to continue raising awareness from the people side so we can raise the voice high. This is when the policymaker will listen to that voice. And then we're going to facilitate your job, Heather, where you don't need to introduce what is endometriosis to the senator or anybody, because now they know about it. And I feel like most of the changes happen through that route.
Absolutely. I mean, anytime you put endometriosis on the map, good things can happen. Good things can come from it. And I know I say this all the time. We're pushing a boulder up the hill all the time. But we do have accomplishments. We do get achievements. I mean, if you look at Jillian Gilchrist's, Representative Gilchrist's efforts in Connecticut, endometriosis was not something on her radar. It was a constituent that brought it to her. And what did she do with that? She turned around, she formed an incredible working group. We wrote legislation. She got it unanimously passed. They're funding a biorepository. They're funding an educational movement. It happens. It just doesn't happen overnight as much as I wish it did.
So we're talking about future directions in terms of endometriosis. Dr. Mawad, I believe you have a bit to share with us.
Yes. I want to share with you now how we're advancing through artificial intelligence, the surgical part and the surgical aspect of endometriosis. So if I can share my screen, I can share some of the videos that I have, which would be very interesting and very important also to make sure that these are surgical videos. So if this is a disclaimer, if you're afraid of that, then you should run away right now. So for me, this is one of the easiest thing that we're starting with is the segmentation. This is a patient who came for hip endometriosis. And then now what we could do, virtually 3D print the model, where we can see here the endometriosis, how it's going through the hip bone, invading all the muscles. Now, the yellow is the bladder, the white is the uterus, and the brown is the colon. And now that new systems will allow us to localize that lesion, which is here in dark brown, and its relationship to the ureter, its relationship to the bladder, its relationship to the pelvic muscles, and then help the surgeon prepare such complex surgery, help the surgeons invite the multidisciplinary team to tackle and then strategize ahead of the surgery, and be able to show the patient, in addition to counsel the patient about what's going to happen during their surgery, which is the most powerful thing. So this is what technologies enable us to do. I'll show you more videos about this is a new algorithm to predict the bleeding during surgery. And we know surgery in endometriosis. Now you see the bleeding where it's going to happen before you see the blood. So that helps a lot of surgeons being able to be cautious on major blood vessel or even smaller blood vessels before it happens, so they can tackle those blood vessels and minimize the damage if they can. Again, here, this is a bowel endometriosis, and you can see a rectovaginal endometriosis. It's extremely difficult to separate between the nodule and the bowel. And when we can enhance the image of the bowel, now you can see a clear delineation between endometriosis and the bowel, and then it allows the surgeon to dissect into safer spaces, make sure they excise completely the lesion while protecting the main organs. Now you see the image before and you see the image now. It's completely a different image where now the surgeon is being able to see accurately where is the bowel and where is the endometriosis nodule in that sense. So all these advancements are to enhance the ability of the surgeons to do safer surgery for the patient. Now I can show you a little bit more stuff since we are here about the newer algorithm that was created for not the very experienced surgeons to understand where is endometriosis and where is the adhesions and where is the scar tissue. This is an artificial intelligence program that could in real time detect the superficial adhesions, the deeply infiltrative endometriosis, in the surgery at the same time. So that helps surgeons that they don't have experience with the endometriosis, at least when they do the diagnostic laparoscopy, help them manage the endometriosis or stage the endometriosis appropriately before sending them to the endometriosis excision specialist. So there are a lot of things ongoing right now in the realm of artificial intelligence, augmented reality, even for adenomyosis surgery. You can see with adenomyosis, sometimes it's extremely difficult to identify adenomyosis. And then here what we do is we can segment the MRI imaging and then help identifying the lesion of adenomyosis here in the uterus, overlay those pictures for the surgeon in real time during surgery, so the surgeon can locate adenomyosis precisely and being able to excise it rather than doing a hysterectomy for patients who require to spare their uteri. So these are novel technology that's going to enable surgeons to perform safer surgery, more accurate surgery, and be able to offer more stuff for their patients. So this is some of the stuff that I want to show you, a sneak peek into what life could look for the near future. And then I hope that people would like it and will see a value for them in it.
Well, you are living in the future, Gabby.
Absolutely fascinating. I wonder, I know you operate in Europe. Are they implementing more of that in Europe than over here, or you don't see a difference?
Yes, yes. Now there is a company that I work with. It's called Surgar. It's surgical augmented reality. Another company, H3AD, which is also a company for segmentation. Another company that I work with in artificial intelligence and MRI reading. So that helps radiologists read endometriosis more accurately. So all these companies are there are a lot of programs where they're started implementing their boxes where you need to collect a lot of data before you can teach the machine how to identify things. So you need thousands and thousands of surgical videos, you need thousands and thousands of MRIs, so you can train the machine how to identify accurately endometriosis and how to help surgeons, during their surgical time, identify those lesions or map those lesions accurately.
Fascinating. And
It is. It's very fascinating.
do you think, Heather, you've been around a long time, do you think that that would help with training? Because so much of endometriosis is recognizing it, right?
Absolutely. I mean, this seems to me to be the natural progression, of and the evolution of training, but also helping surgeons to improve surgery, improve the quality of surgery, pre-surgical planning, and ultimately that benefits the patient, because what do we talk about all the time? Informed consent, right? So this just seems like the natural next best step. So it's fascinating. It really is.
What do you think is out there in terms of radiology and AI for endometriosis? I think that would be a huge step in the right direction, because we don't seem to be getting the best results all the time radiologically. I don't know how to put it well, because if you know what you're doing, then you know what you're looking at. If you don't know what you're doing and
Yes.
you're not coming to our course, then you're not really going to find the endometriosis.
Well, that's the problem, right? I mean, everything is operator dependent, from surgeon to radiologist to whomever you're working with. So if they don't know what they're looking at, or they can't perform it, and this is a real problem. I mean, sometimes if you're sending a patient for a certain protocol and the center says, we don't even know what that means. I mean, it's a problem. So I think anything that helps increase recognition and standardizes the approach so that anybody can understand and look and do and take in a patient that needs it, I think that's really important. But it is very operator dependent right now. We're not anywhere near where we need to be.
No, I agree, but for me, I think those interventions should be done for the general OB/GYN, so we can create safe referral patterns for our patients. Because, like, for me, if I'm a general OB/GYN, I found a lesion of endometriosis that is beyond my area of expertise, I'm gonna say, like, oh, I don't want to deal anything with that. I'm gonna refer them. But unfortunately,
Absolutely.
most of them, oh, we didn't think your case was gonna be that complicated. We're in 2024. Now, we know precisely what we're doing before we go to surgery. So it was too hard. It was the hardest case that I've ever done. We had to call a surgeon. You should know beforehand to call a
Should
surgeon.
absolutely
Not
know. I
surgical
mean, yeah,
surprises.
there
This is
should be no
where the
surprises.
disaster happens. And I feel if we can use technology to minimize those surprises and those disasters and establish a safe referral patterns for the right providers, that's going to be the value of technology for us. The expert surgeons are doing beyond the curve, and probably some of the AI could help us, maybe seeing things that we cannot see with our naked eye or with our surgical eye, so we can excise even more and then minimize the chances potentially of recurrences. But for me, I think the general population, all these interventions should be addressed to the general populations.
Oh, I agree completely. I mean, it's really about precision medicine, right? And part of precision medicine is knowing when to refer, and that you should refer. I would much rather, if I'm wearing my patient hat, I would much rather sit in an office across from somebody who says, I'm not capable of doing this, I'm going to refer you. I have much more respect for that than the cowboy who's going to go in and cut my ureter. Or, as you said, we weren't prepared. You're the sickest, worst case ever. We have to go get a new team. You should have that team with you. The team should be in the room. So it is. It's about precision medicine. And I think all roads lead to that. And these are the tools that we need.
Heather, we have an interesting question from the crowd. Or actually, Dr. Mawad, you could both take a shot. So how do you, if you're somebody seeing that general OBGYN, regardless of technology, how do they sort of convince them that it's time to be referred out? I think we teach vote with your feet, but some people, it's not so easy with their insurance to do it without a referral.
No, that's true. I mean, the burden really lies on the practitioner. They have to have the integrity to say, I don't think I can treat this. I am going to refer you. It should not be the burden of the patient to know or decide whether or not that doctor can treat their disease or even recognizes their disease. They're supposed to be able to trust in the healthcare system. And I think with endometriosis, there's a lot of mistrust because that's been the case historically for so long. We've had enough of elitist paternalistic medicine. Patients are empowered. And I think that's where the discussion comes in. That's where the Q&A comes in. You know, we teach them, here's a list of questions. Don't be afraid to ask. Oh, and by the way, here's sample answers so you know what to gauge and what to look for. But it's not on the patient. It shouldn't be on the patient. You know, if they're with someone who is not a high supporter of their goal towards whether it's excision surgery or they want to be referred somewhere else or medical therapy, whatever they want to do, if their physician is not a high supporter, that's probably not the right physician for you anyway. But it is difficult. You know, there's barriers to access quality care. You know, there's socioeconomic, there's location. I mean, not everybody can certainly sell their house and get on a plane, right? That's ridiculous. So you have to deal with what you have where you are. And I think you just have to be honest. Sit across the desk, have that conversation with your clothes on, not while you're having a pelvic exam, and ask the questions. It's your right. It's your right as a patient.
No,
Dr. Awad.
as simple as like for me, as simple as the patient should ask, you know, thank you so much for your time. I really appreciate what you told me. I'm going to do my own research. I would really appreciate to get a second opinion so I can make up my mind. As simple, as frank as that. And if the physician is defensive, that means they're trying to hide something, because most of the people are defensive when they're not confident or where they're hiding something.
Right.
I don't think 90% of the time it should be okay. When doctors are defensive, you should run away anyway.
I agree.
Heather, but he's telling the truth. He speaks the truth, but he's not a patient. So I've never had a doctor that isn't a high-end specialist that I've said, hey, I'd like to get a second opinion, that they didn't answer from their ego and go, well, you can get a second opinion. Like
But-
you're, you know, in a very gaslighty, passive aggressive, you know, well, Lupron is the standard, but you could get a second opinion if you want to see, oh, you want somebody to read your actual MRI, you could get that second opinion. Like it's always said in a
way.
Yes.
Yeah.
But
You know, I mean, you know my situation. I'm not going to go into it, but
Right.
you know that I'm dealing with other specialists from a different discipline. What I have found is that there are no egos anywhere in medicine like there are in cardiology, right?
Oh, well, that's true. Or
But
plastics. I had a plastics
Yeah.
emergency. Wait till you have to deal with the plastics. Yeah.
But I have been fortunate enough in that they have been very open, but I think it's the way that I approached it too. And I admit I'll go in there with a chip on my shoulder right away because I'm already expecting you to tell me do yoga about it, right? So I kind of
Lose
go
weight. That's the number one thing they say.
I kind of go in there with that aggressiveness, and that doesn't work for everybody. But I think again, it kind of, you know, it waters down into more of an honest conversation. We have a really sort of an interesting new program too, at one of my hospitals. They have a second opinion, surgical second opinion program. You know, my nephrologist is there, my cardiologist is there. There's a whole bunch of specialties there. Love to see that everywhere in the country. I don't know how they did it. You know, I'm not involved professionally in that way with them, but I just thought that was so fantastic. And folks can go there and have a conversation with them and talk about their case and, you know, talk about their situation.
Another way, I think, like a patient can always call their insurances. Patient can call their insurances and tell them, like, I want a referral for another specialist. I'm not satisfied with my doctors. And then the insurance will grant them that stuff many times, because I believe insurances listen a lot of the time to patients because they're afraid. By law, they cannot, most of the states, there is a law that insurances could not interfere with any patient's medical decision. And this is a law. So they try to use sneaky ways to direct them to in-network, into their in-network providers, but by law they cannot force them. So I think many of the patients that I've seen call their insurances and advocate for themselves, and they were able to grant them like a gap exception to see an out-of-network or. You know, it depends. I feel like it's a tough situation because now patients are delving into things they're not supposed to do. This is a failure of the healthcare system and failure of the education and the training and everything that's forcing patients to deal with things instead of going to take care of themselves. They now have to take care of the insurance, how to get a referral, how to advocate for themselves. And this is not fair, but unfortunately, this is the current landscape right now.
It's very interesting because in cancer, it's approved because cancer, of course, they get this first. It is approved for reimbursement to be a patient navigator. And I think, Heather, you have the background as a BCPA, but I think that patient navigator and chronic illness and endometriosis should be like a high ask on our list, because you're trying to hold down a job, you're in terrible pain, your pain gets maybe worse every couple of months, maybe you're managing a family, maybe you're managing bills, it's a lot to now navigate your care. And we do have a new sponsor that's busy suing over those little tiny gaps in the law on behalf of endometriosis patients and claims he's winning. So, which I hope everybody meets him when they come to the summit. But I think this concept of patient navigator is a time it's come, right, Heather?
Oh gosh, I mean, everybody should be given, at the bare minimum, some sort of advocacy slash navigation support, and that may be, you know, that what it looks like is different for different people. It may be your caregiver, it may be, you know, a friend, or it may be a professional, or it can be anybody. But you know, this, you're talking about holding down a job. I mean, there's folks that can't work. So, I mean, there's all kinds of different challenges that go into just trying to live with the disease. And now you have to be a full-time professional at managing your own care. I know that Alex, Invisible Iconic, she has a whole panel that she's been doing on, you know, administration, you know, getting my records, getting care, going to the doctors, doing this. It's a full-time job. So yeah, I mean, anybody that can have support or enhancement of their experience in any way, I'm big on that.
Yes. So I think that we have some questions about, you know, what do we think is on the horizon for endometriosis that may help mitigate that sense of trauma and that sense of gaslighting that we all feel. Even Heather, you come into a doctor's office, guns blazing. I do too, because of our past experience. So we see, you know, that there are some technology advances. What do we think it's going to take to really change that? I don't have any idea.
You know, I think this is a really nuanced question, because on the one hand, we have such incredibly educated self-advocates in the patient community. On the other hand, we have you know, folks, practitioners who are starting to lean more towards things like trauma-informed care, looking into patient-centric care, all the really good things that we want to see. But then you have, over here in this part of the community, you have a whole contingency of people who do not respect the patient as the narrator of their own experience. They do not respect patient involvement in the practice of research and things like that. Interestingly enough, they happen to be the same people who are taking options off the table. So,
well, it's interesting because I had
it's hard.
A lunch with all these IV trauma people and OBGYNs and who work in menopause. And first of all, they didn't know what the word gaslighting was. I'm like, you're a therapist who does EMDR. Like, how do you not know what the word gaslighting is?
Right.
And they couldn't understand, like, do you feel traumatized because you weren't able to have a child and you miscarried? I'm like, no, that is not what we're talking about. And I don't think academia takes this very seriously.
I mean, it's more of the ivory tower, you know. There are very few people who can sort of bridge that gap and come in the middle. We see it a lot in PT. You'll find a lot of people in your profession who really are in that middle and they get it.
But they
Outside, not
get
so
it.
much.
But there are some who take the courses, you know, like we wanted to bring this this probably does not interest Dr. Mawad, but we wanted to bring this very famous guy. And the issue is when you really go through and you speak to them, there's an element sometimes of patient blaming to trauma-informed care that maybe we don't get it because none of this is ever the patient's fault.
Well, remember, I mean, look, medicine is an art and a science, right? And you're dealing with humans. We're not treating a little tiny lesion and then everybody goes on their way. You are dealing with a human here, a human here. Sometimes folks are just not meant to mesh. So it's really about finding the one that you mesh with, that you want to take that journey with.
But plus, like, when we're talking about like a chronic disease, most of the healthcare system nowadays is designed on encounters. Patient comes in, finishes, goes away. None of the modern system is designed to treat the patient as a whole. They treat them as an encounter of care. So, and we keep giving that example. Like for me, even if you're a surgeon that wants to treat something that you're not good at, so if you go with endometriosis, dig in some of these spaces, and now endometriosis invades into more serious places. So if you send the patient to, if the patient end up in a different surgeon, so if we need now to cut your ureter to reimplant it just because endometriosis invaded it, that should be the fault of the person who dug in or misdiagnosed. It's not the surgeon who did now the correction. But unfortunately, the healthcare system does not recognize those things. So I go to you, you treat me for something, you finish, you go. And unfortunately, this does not happen with endometriosis.
Right.
Because endometriosis entails a lot of intricacy and complexity. That's why the healthcare system will always, the modern healthcare system, the volume-based healthcare system will always fail the patients with endometriosis.
Sure.
We don't have a value-based care. We don't have patient-reported outcome as part of the reimbursement. We don't have any of these kind of things that will enable us to serve better the patients with chronic diseases like endometriosis and
Sure.
many other diseases, I believe. So unfortunately, that's why patients with endometriosis find themselves like they're being bombed by multiple specialists. Look at their files. They have seen 65 specialists. They're 25 years old.
Yeah. Oh, yeah.
So because
Us.
and everybody works
That
inside.
was us.
Well, I also think the other problem with that is that when they hit 66 specialists and that particular specialist system, okay, in a very paternalistic way, this is what you're going to do. You need to be beholden to whatever treatment I'm offering, that it puts people at a risk to not be able to use their own computing skills. And I see that over and I've seen it with the rise of advocacy, because we've made sometimes what we call super surgeons, and that patients can get like sucked in ways that they're not using their own voice anymore.
Oh, absolutely. Absolutely.
Yeah.
I think the pendulum swings in both ways. I mean, you can oversaturate for surgery, or you can swing the other way and, completely demonize surgery. When in reality, there are people that need surgery and they should have surgery by a qualified, competent endosurgeon. People want to take surgery off the table and it's ridiculous. The people need more options with endo, not less.
Yes, I completely agree.
I know when I sat through that, I was actually, because he's involved, you are too, with the AAGL Foundation. I think they should run a day on the Hill. Because I think like it's one thing if ACOG is going to sit there and do, I know you roll me, or I could be a dreamer, Heather, it could happen, right? But if ACOG does it, they're not going to have the voice of the, right.
What?
They're not going to have the endometriosis voice, but they're not going to have a voice of a minimally invasive surgeon either. And
They'll
only
have the voice of a minimally invasive surgeon who is a parrot that echoes everything that they say.
wow, we don't really need that.
We have enough of that.
Well, guys, like let's be positive tonight and tell them
Oh
about.
wait, we're gonna get into an even better conversation. What
You know
role?
it's
So
better than that.
So when I pulled into Florida, we actually drove past our second hotel, which is the Malia, which is where we were yesterday. We were there this afternoon, and I was thinking about the last time I was there. I was taking Dr. Redwine to the airport.
Oh,
And then everybody got sad in the car. And but let's in the future, because Heather, this involves your talk this weekend. What role do we see our friend Samson still playing in the, like, be honest, like, are we going to get enough advances to realize that endometriosis is not from retrograde, or is he still going to be dominating everything? What do we think about Samson in the
well, I
future?
don't want to give away too much of my talk, of course, but no, I mean, I think that you are always going to have the hardcore Samsonites, and that's okay. But we have to remember that what is published or what is preached, that has a direct impact on patient care. And I talk about this in my quickie talk on Sunday. The important thing is when we're talking about theories, and again, it's about, bringing more to the table instead of taking away. Retrograde may very well play a small role. Okay. The endometrium may play a small role. But what people are not really understanding that are fans of the Samson show, it's about understanding that it cannot possibly account for all cases of endometriosis. So there has to be a different pathway. There has to be additional theories. And I think refusing to embrace those theories just keeps us mired in 1927. Okay, so I think we'll talk about this on Sunday, of course. Again, you're always going to have people who believe it is just a period disease and that it's just normal native endometrium, sort of hither and yon in the body, and we can give you a hysterectomy and you'll be cured. If people are committed to misunderstanding, you cannot reach them. The best we can do is put the education out there.
If we have the AI to show, like Dr. Mawad was showing, right? If you need thousands of surgery videos and thousands of scans, and we're getting those to build the technology, and we're able to show that, like, you can show a bowel now much easier, then I think, like, it's going to push people away from that it's only about the period, because now eventually I would say 5 years worth of AI, you're going to have a lot of data on how much it's, and Wendy would love this conversation, how much it's in the bowel, how much it's in the lung, how many cases perforate from the diaphragm through to the lung, things like that.
Absolutely. It's all part of the progress, and I know it seems very slow, and it seems impossible a lot of the times, but the reality is we're not 20 years ago or 25 years or 30 years ago. We're not doing laparotomy. We're not, doing hysterectomy on every single person that walks in the door. There has been a huge groundswell and bigger body of understanding about the disease. And I do think that people are finally starting to let it sink in. I mean, if you just look at, the usual media reports, right? Last year, or even earlier this year, 9 out of 10 would have been, it's internal periods and other nonsense. Now, if you look, a lot of the coverage that the disease gets, they're using the right terminology. They're talking about the disease as systemic, body-wide, not just a menstrual period, not just a menstrual disease of people with uteruses. They're really starting to get it and understand it and recognize that it is a systemic disease. So I think there's been a lot of progress in that. I mean, we still have to keep our eyes open, but there's been progress.
There's a lot of new nice press, but nothing about the Endo Summit.
But
Well, we got to work on that.
I know.
For me, it's also like we have to keep an eye on, most of the time, the social media created platforms that are extremely powerful, yet they could be very damaging. Because now I look at a lot of information circulating about endometriosis and see a lot of it is erroneous. And then I feel that could create a pendulum that is really will become very difficult for the patients to gauge what is the true information, what is the wrong information. So
I would add a third category to that. What is the information that the wrong information people don't want you to see?
Yes, I completely agree. It's really becoming very manipulated in a way that, like, I was reading a couple of days ago that the new discovery of medication for endometriosis, and yet it's another form package from different medication that's been existing for like 30 or 40 years. And then unfortunately, these people are very smart when it comes to market because they sell hope. And selling hope is extremely powerful, especially for patients who the healthcare system failed them and they're finding a glitch of hope somewhere. And they think like, oh, now we know that there's a bacteria that causes endometriosis. As much as it's a nice scientific stuff, it was done on some kind of animals that they don't have any related, and many of these theories do not explain everything that what we do. There might be a million things ongoing that we probably don't know. Like nowadays, we see an influx of all the diagnostic tests for endometriosis. But why do we need to spend billions of dollars since we have the hearing as the best diagnostic test for endometriosis? Your patient tells you their diagnosis, just you need time to hear, and they will tell you everything you ask.
Because Gabby, that doesn't make anybody money.
Yes, that's what I'm saying. And then now we have an influx of patients that the sister or the cousin was diagnosed with one of those tests with endometriosis. Now she has a positive test. She doesn't have any symptoms. What do we do with those patients? Zero symptoms. Even if I ask her 3 billion questions, if I try to find the reason so I can, nothing. So now we're creating more conflict with the patient. That's why I believe we have the ethical the ethical bound towards our patients to assess every new technology and to see whether it fits our patients or whether it is safe for our patient. This is our ethical bond, and then this is what we can give to our patients, because the future of endometriosis is mainly if I can divide it into three things, is mainly rational, because like we have to assess every single technology that is coming, every single medication that is coming, and see how it fits our patient. It's emotional for us because we want to take pride in what we do to our patients and the way we treat our patients. And most of it's ethical because we have the ethical bound to protect our patients. And then this is the most important thing that we're going to face. I believe technology is going to help us tremendously in the future, but we have to always be very ethical in when we look at technology. Now, all these drugs that are coming, billions and billions of dollars are spent. They are producing more complex endometriosis for us as surgeons. If we support them, that means we're roping our patients into a more complex surgery, because like, let's put a patch that we don't know what are the side effects on that patch, and come back in 5 years where I need to call like 65 surgeons so I can do a 9-hour surgery for you.
Yes.
When I can do a 2-hour surgery right now, and then we'll remove all the lesions. So this is the stuff that we're facing mostly when it comes to the future of healthcare and endometriosis and technology and innovation and test and medications.
All of it. It should be the road towards helping the patient receive much more timely and higher quality care. It should not be yet another roadblock for a patient to obtain that care or be believed. Well, your scan was negative. I don't believe you have endo. Okay, but I still feel horrible. Can we do anything? Yes, here's, a second tier drug that has really awful side effects. Just take it. We don't know if you're diagnosed or not, but just take it anyway. And then what do? They end up at our centers, right?
Yeah, I think, but we hit the nail on the head when we say, we're so desperate for that not to happen that we're like prey for a lot of I get calls all the time. All these new technology companies, they all want free tickets to the Endo Summit. They don't want to pay a dime to sponsor. And can they use my crowd to do studies on? So I get a lot of these calls, and I think, you know, they all want to be the great hope because people are desperate, but we have to still analyze whether or not they're worth it. So we have an interesting question, which fits with the Endo Summit this week, because we have Dr. Carmona coming. Gabby, Dr. Mawad, do you feel that there are differences between how disease is treated in Europe and how disease, not necessarily the way you treat it, because you do a good job all the time, but how disease is treated in Europe versus how disease is treated in the United States?
Well, I realized that in Europe, the wait time for patients is longer than if they find the right surgeons. Because in Europe, most of the healthcare system, there are government supported. So they have guidelines to follow. Oh, we need to put you 6 months on birth control pill, and then we need to do this. We need to do that. So the access of care might be more limited in those countries. The wait time for surgery is longer, and then you get the more advanced endometriosis because these patients have been, long time waited. I think there are amazing surgeons. They do a great job. But at the same time, we are all the same human being living in different places. There are the gaslighters, there are the generalists, there are the surgeons that claim they can do stuff, they don't do anything. There are the people that do half of the job. So it's very similar because we are both the same. But I believe the access to having a surgery in the US is way quicker than in Europe because they are bound by list and list of surgery. We did this project in the Nordics where we tried to do 100 surgery in 1 week for endometriosis to cut down the lines of that. We were able to do 60 only, but the lines for surgery, 6 months, 8 months to get to surgery. And these are one of the more advanced healthcare system in the world, like in the Nordics, Denmark. So that's why it's sad for us. We're blessed here. Unfortunately, the hit or miss, because most of the insurances controls the patient's direction to care, where they should take them, the in-network, the out-of-network. We are the most expensive healthcare system that does the worst job in the world.
No arguments there.
It's like we pay a lot of money there. Like if I wait 6 months, I'm getting my surgery free. I'm going to the biggest university hospital. There is at least something in return. But here the patients are paying money every month to get an insurance, yet going to pay deductible to do that. Yet the insurance will send them to in-network general physicians that might do a bad job. So that all investment that they paid to get a healthcare insurance to be safe is gone to be a bad investment.
Yeah.
So that's the differences between both places.
All right, we are rounding out our Endo Summit Live. Endometriosis Summit will start now in, I think, 71 hours. But we'll start in 4 days. You can purchase your tickets virtually. I think we're going to www.theendometriosissummit.com. So, Ms. Guidone, what do you look forward to the most about the Endometriosis Summit?
Well, every year, usually it's just about being with everybody. But since that's not happening this year, I'm interested in just seeing any and all of the incredible programmatics that you have going on. I mean, I've been with you since the beginning, and I know how hard you work putting your summit together. And every year I say the same thing, that you've outdone yourself, but you really did outdo yourself this year. I've watched the schedule, I've seen the schedule over the past few months, and it's just so all encompassing. And I think that we all learn from each other. There's nobody in endometriosis that has all the answers, despite what they may think. So we are all learners, and I'm looking forward just to learning from friends and colleagues and new faces.
Yeah, tomorrow I have to look for 150 yellow tablecloths because we sold so many tickets we couldn't fit at the real tables that already
Oh,
came
no.
with the tablecloth. I mean, and this is my life. So, Dr. Mawad, aside from you deciding to be in France during the endometriosis summit, which I guess is a hardship, what do you look forward to every year about the endometriosis summit? And now keep in mind, I could suck you right in for the AI panel next year that Dr. Wasson and I are planning. But what do you look forward to about Endo Summit time?
Well, for me, it's like I was at the first one, but since then you keep getting me on the schedule where I'm already committed to something. But for me, it was an amazing experience because this is the first time for me as a surgeon I can get in touch with a lot of more patients. And most of us learn mostly from our patients how to do better for them, how to listen to them, how to see a different side of the story from a different side of the table that we're sitting at. This is what makes you a better human, yet let alone a better physician when taking care of patients with endometriosis. And I think this is an innovative, unparalleled experience that I've experienced in my life with the Endo Summit. And then since then, I made a lifelong friends through advocacy groups like you guys, and then that I cherish and I learn a lot from. Because for me as a foreigner, I I changed a lot of things that I've done in the sense from my English language to the terminology to things,
Oh,
and it was all because of you. But now
see?
it's amazing.
Well,
We
we love
love hearing that. I think we did not do a library this year, but each year you've been in our library. And we'll work on not being on International Women's. So see, if
Yeah.
we are held in Florida, what happens is we can't be the week of spring break because then nobody can get in anywhere. So then we end up falling earlier. So maybe you should talk to the other people about moving. You should, and then
No,
we
next year, even if I'm gonna travel back, I won't miss the endometriosis
right.
summit.
We try not to be at the end. We don't like to go last, but we try not to be at the end because there are other groups that are always those weekends. So somebody else had to go. I mean, already there was technically one last weekend, but anyway. All right, we are rounding it out. We will see you this weekend. If you enjoyed this series, we start them again next December. Take care, everybody. Good night.
Thank you.
See
Bye.
y'all soon. Bye, everybody.